Hey there, I hope you're all doing good. Welcome back to Prepladder NEET Assess. This is Dr. Santosh Patil, and in this video module, we will be discussing sleep disorders. Well, sleep disorders is kind of topic from which you do get 10 marks questions on your final MD prof. And of late, we have started seeing a lot of questions, clinically oriented questions asking you to differentiate between different sleep disorders. But before I get going with the topic, let me tell you that I'm going to keep this video module very succinct and focus primarily on what is important for NEET SS and maybe your MD final prof. Because when it comes to sleep disorders, the spectrum of disorders that come under this heading is extremely wide, and sleep disorders or sleep medicine in itself is emerging as a specialty nowadays. So it becomes very extensive for me to cover everything. My focus will be on obstructive sleep apnea, obesity, hypoventilation syndrome, and narcolepsy. These three are very important when it comes to NEET SS. Okay. Now, most of the questions that I've seen in the recent times, in last 4 or 5 years coming from this topic, maybe 2 or 3 questions, the questions are primarily asking you to differentiate between these three entities. That is the most important conceptual area that we need to focus on. Beyond that, what is the first line management, second line management, investigation of choice, and diagnostic test interpretations. Those are going to be important MCQ areas. So what we do now is that we will go through some MCQs that will help us open up our mind to the key concepts which we will be discussing subsequently in the video. So this is my first question. Which of the following sleep disorder is associated with low CSF hypocretin 1 levels? Okay, so like when I see this question, first thing that comes to my mind is the diagnostic criteria for which of these disorders actually mandates a CSF analysis. The question can be remolded that way, right? Options are OHS, obesity, hypoventilation syndrome, obstructive sleep apnea, narcolepsy, and primary snoring. Okay, if you know the answer, well and good. Otherwise, you should be able to answer this question after this video module. Okay, this is the second question. A 40-year-old male, obese, hypertensive, on treatment, presented with history of snoring at night and increased daytime sleepiness. ABG done during the daytime shows PO2 of 81 millimeters of mercury and PCO2 of 58 millimeters of mercury. pH is slightly on the acidotic side, 7.32. What is the most likely diagnosis? Obstructive sleep apnea, obesity, hypoventilation syndrome, primary snoring, or medication-related sleep abnormality. So what do you think is the answer here? Right, this is probably the most important question or take-home message this question carries for NEET SS. Okay, again, if you're able to answer, well and good. If not, we should be able to answer this question at the end of this video module. So what we will do now is we will take up these sleep disorders one by one. But as we go along, we will try to understand the key pathophysiology and how it is different from other closely related differentials. So the first entity we're talking about is obstructive sleep apnea. Right, as the name says, there is obstruction and there is apnea. Okay, and its consequences are the patient's symptoms. Now, where is the obstruction? Obviously, airway. Which part of the airway? Predominantly upper airway, right? And this obstruction is happening during sleep. That is why we're calling it as sleep apnea, obstructive sleep apnea, right? And this obstruction is leading to apnea. But this apnea is not central apnea. That means the respiratory center, which is there in the brainstem, right, your nucleus tractus solitarius, where the respiratory center is located, that is functionally working fine. Despite that, there is reduced airflow. The reduction in the airflow, which we are now defining as apnea, is because of the obstruction. It is not because of the reduced respiratory drive. When the respiratory drive is reduced, we will call it as central sleep apnea, right? Okay, so that is the basic thing we need to know, obstructive sleep apnea. Okay, now what are the risk factors for development of obstructive sleep apnea? Obviously, any anatomical abnormality of the upper airway where there is obstruction, right, can be a risk factor. So upper airway anatomical abnormalities, definitely yes, can be an important risk factor. Okay, then obesity, like we all know, is an important risk factor for the obstructive sleep apnea, right? And family history. Though family history for OSA is not as important as the cases of narcolepsy. Narcolepsy family history is a strong predictor, but many patients who are diagnosed with OSA do have family history. Okay, these are important risk factors for development of OSA. Okay, now what is the underlying pathophysiology and why are we giving so much of importance to OSA? If it is just related to obstruction and some disturbed sleep, then probably this disease does not require the attention that we are giving. It is not only related to the sleep symptoms and its consequences during day, but it is also associated with increased risk of certain other medical disorders, right? So what are the conditions whose risk is increased if you have OSA? Patients with OSA are at increased risk of developing, number 1, hypertension. Number 2, they are increased risk of developing diabetes mellitus type 2. And they are at increased risk of developing pulmonary hypertension. So can I say that because patients have all of these comorbidities often evolving over time in them, if they develop the obstructive sleep apnea, can I say that there is increased risk of mortality? Yes, definitely yes. There is increased mortality risk in comparison to general population. And also the quality of life of patients with OSA is significantly affected, not only because of these comorbidities, but as such the sleep disorder itself impairs their quality of life. So they have poor quality of life. That is why the disorder requires a lot of attention. Now talking about its pathophysiology, what is essentially happening in these patients is these patients have episodes of upper airway obstruction during sleep. Okay, why this upper airway obstruction is happening? Most important reason is that they might have an underlying structural abnormality of the upper airway. Plus, normally when we go into sleep, some physiological changes happen. What are those changes? Parasympathetic nervous system gets activated, so your heart rate slows down, your cardiac output comes down, your metabolic rate decreases because your sympathetic activity is reduced. Then you also have reduced muscle tone or hypotonia developing. Like these are all physiological changes that happen during sleep. Again, yes, during REM and NREM there are different changes happening. The sympathetic nervous system gets little more activated during the rapid eye movement phase of the sleep. These are all physiological changes. So these physiological changes coupled with either anatomical abnormalities of the upper airway or obesity, which is also as such making the airway space available for the airway narrower. Like there is a lot of fat around your neck and the upper airway, so that has already reduced the scope for the upper airway. Plus add hypotonia, that reduces, like the patency of the upper airway is reduced because of the hypotonia. The muscles are all making it collapse onto itself, and that leads to obstruction. So there are episodes of upper airway obstruction. Now when upper airway obstruction develops, obviously this will lead to hypoxia, right? This will lead to hypoxia. And when hypoxia is happening, obviously your respiratory center in the brainstem will sense it and it will try to compensate. So there will be increased respiratory efforts, to overcome the hypoxia that is evolving. And we have to understand that both of this, hypoxia and increased respiratory effort, will trigger arousals. I would rather call them as micro arousals, because what happens is most of these arousals are lasting for seconds, not in terms of minutes, right? Like you develop an episode of upper airway obstruction because you went into sleep, muscle tone decreases, and you already had other comorbidities like obesity or anatomical abnormalities of upper airway, and you start developing obstruction, hypoxia sets in, and it triggers arousal, right? Now once you are aroused, patient develops arousal, and once he is aroused, the muscle tone improves, right? Your respiratory effort is more efficient now, and the hypoxia is overcome. So there will be improvement in airway obstruction and hypoxia, and that will lead to, so sleep had triggered the episodes of upper airway obstruction, and once there is improvement in the obstruction and hypoxia, patient goes back into a good sleep now. Okay, once he goes into sleep, again the muscle tone decreases and episodes of upper airway obstruction kick in, and the patient keeps rotating through this cycle. But as an offshoot of these cycles, right, one is there are multiple micro arousals. So obviously body will try to squeeze the required sleep out of the patient. During night time, he did not have a good quality of sleep. He may or may not be aware about these arousals. Majority of them indeed are not aware about the arousals. They are all micro arousals, which we can see on the EEG as intermittent appearance of alpha waves. Alpha waves on the EEG are suggestive of awake state, right? So this will lead to increased daytime sleepiness, because the body will now try to squeeze the sleep it needs. It demands the sleep. Increased daytime sleepiness, because the quality of night sleep was not satisfactory. Okay, and obviously when you feel sleepy during the day, right, you also feel tired or lethargic, and it will impair your quality of life. So quality of life will be impaired quality of life, right? Now also this hypoxia and the increased respiratory effort that is accompanying is also triggering some of the other metabolic adaptations. What are those? There will be increased activity of the sympathetic nervous system during this period. Increased activity of sympathetic nervous system. There will be production of hormones which are generally considered as counter-regulatory hormones, right? Like for example, increased production of cortisol, adrenaline. And if you know that, if you have already analyzed the CGM or continuous glucose monitor of diabetics as well as normal individuals, you would know that the nighttime glucose levels are on the lower side. But if there is an awakened state, these counter-regulatory hormones push the glucose levels up, right? So that can also happen, and to counter that, there can be production of glucagon. Now all of these, right, in the long run also increase your insulin resistance. In the long run, I'm not talking about an acute event. Insulin resistance increases in the long run. Okay, so this increased insulin resistance in the long run can also contribute to development of type 2 diabetes mellitus. And this intermittent increased activity of these hormones and the sympathetic nervous system can also contribute to the pathogenesis of hypertension. Okay, and once these two comorbidities come together, right, it can contribute to, because type 2 DM, there is insulin resistance involved. So that also contributes to the evolution of dyslipidemia. So now patients can start having dyslipidemia and micro as well as macrovascular complications related to diabetes mellitus, and also augmented by hypertension, and thus there is increased mortality and morbidity in these patients. Okay, now this increased daytime sleepiness can also contribute to accidents at workplace, especially if they are laborers where they are working with dangerous goods or equipments. It can contribute to accidents at workplace as well as road traffic accidents. So this is the plethora of manifestations of obstructive sleep apnea, and that is exactly why we need to promptly recognize and treat these cases. Okay, now how to recognize obstructive sleep apnea? How do we diagnose? For the diagnosis of the obstructive sleep apnea, we follow the diagnostic criteria laid down by diagnosis of OSA. It is based on American Association for Study of Sleep, right? American Association of Sleep Medicine or American Association for Study of Sleep Disorders. We follow the AASM guidelines. Okay, and I have got myself updated from their website till 2023. So we're going to discuss whatever I'm covering in this video module will be up to date. So if you're writing your MD exam this year, you can just rely on the points covered here and you can replicate your answer. Okay, so for diagnosis, first question is, how do we diagnose, right? Is it based on the clinical features alone, or do we need investigation? Obviously, we need investigations. So the investigation of choice is polysomnography. The investigation of choice is polysomnography. What is polysomnography? We can also call it as sleep study, right? Where we're trying to analyze patients' overnight sleep characteristics. And as the name of the disease suggests, obstructive sleep apnea. So we're trying to prove that patient is going through episodes of airway obstruction, right, which is triggering the apnea or reduced airflow. It's not practically possible to measure the obstruction, right? So we can only measure the apnea, which is because of the obstruction. I think in the beginning also I told you that apnea that happens here, right? Apnea is nothing but cessation of airflow in the airway. That is not because of the reduced signal generation by the respiratory center in the brainstem. It is because of the obstruction. And when there is an obstruction, there will be a response to overcome that. So there will be increased respiratory effort. So that it should be there. If there is reduced airflow, but there is no increased respiratory effort, right? That episode will not be in favor of the diagnosis of OSA. Okay. I hope that point is clear. Now, investigation of choice is polysomnography. What are included in the polysomnography? See, obstruction, pathophysiology is obstruction, reduced airflow or apnea, hypoxia, triggering the increased respiratory effort, and arousal. So we're trying to prove this, right? Obstruction cannot be documented, but apnea or reduced airflow can be documented. So we need to measure the airflow and respiratory parameters. One thing we need. Second we need is hypoxia we're talking about. So desaturation can be documented. Then arousal. Obviously, you cannot keep watching the patient directly to document arousal. So the evidence of arousal comes from the EEG, appearance of alpha waves, right? So definitely that means we need SpO2, we need the respiratory parameters, and we will require a EEG. Okay. Then many of these polysomnography tests also include ECG, which is not a mandatory component. When these three are there, it is sufficient for us to make a diagnosis. But then we hear this term called as limited sleep study. Limited sleep study. So when you hear term sleep study or polysomnography, it is a full-fledged polysomnography. But when we hear term limited sleep study, it means it is a sleep study where we are skipping the EEG. So only SpO2 and respiratory parameters are measured and there is no EEG involved. Okay, both of these methods have their own pros and cons. The pro of polysomnography is that the arousals can be documented using the EEG, and that is why this is the gold standard, right? If there is a question asking you what is the gold standard for the diagnosis of obstructive sleep apnea, the answer has to be polysomnography, or the investigation of choice is polysomnography. Limited sleep study, its advantage is that because there is no EEG involved, we can employ this test in patient's home. For polysomnography, patient has to come to a sleep lab, which are only present in handful of hospitals in most of the metro cities. But this limited sleep study can be carried out at patient's home, and obviously something is better than nothing. So most of us kind of in clinical practice rely on limited sleep study rather than polysomnography for the diagnosis of obstructive sleep apnea. Okay. Now in this study, right, how do we make a diagnosis of obstructive sleep apnea? We make a diagnosis of OSA according to American Association of Sleep Medicine. Diagnosis of OSA is made when patient have more than or equal to 5 apnea hypopnea index or apnea hypopnea events per hour of sleep, coupled with signs and symptoms of OSA. Okay, I'll come back to this in a bit. Or we can also make a diagnosis when this AHI or apnea hypopnea index is more than or equal to 15 per hour of sleep, even in the absence of symptoms. So signs and symptoms are needed if the AHI is 5 or more. But if it is more than 15, then there is no need for signs and symptoms of OSA. Even in the absence of it, we can make a diagnosis of OSA. Now comes the question, what are the signs and symptoms of OSA? See, most important thing is impaired daytime quality of life or increased daytime sleepiness. One very important symptom, increased daytime sleepiness or impaired daytime quality of life. One. Okay. Second, this is with respect to the result of impaired quality of life, quality of sleep in the night. But nighttime also there is issues, right? What are those issues? Snoring or snorting or gagging episodes during sleep. So when these are present, along with an apnea-hypopnea index of 5 or more, we make a diagnosis of OSA. And if the sleep study shows that AHI is more than 15, then we don't even need the symptoms. We can still make the diagnosis of OHA. Okay. Now comes the question, what do I mean by apnea-hypopnea index? To understand that, first we have to understand what is apnea. How do we define apnea for OSA? The basic understanding is apnea means stoppage of breathing, right? So here apnea is defined as either complete cessation of breathing. Complete cessation of breathing. When I say complete cessation of breathing here, patient will be having respiratory effort. So the more ideal word will be complete cessation of airflow. Complete cessation of airflow through the airway for more than 10 seconds. For more than 10 seconds. Okay. With increased respiratory effort. These words are very important because if patient doesn't have increased respiratory effort, that means the respiratory center is not triggered. So that means it's a central sleep apnea, right? So when airflow is not happening through the airway for 10 seconds or more, and patient is putting increased effort, then we can call it as the apnea required for the diagnosis of OSA. Okay. Now we should also remember that some of the books and guidelines mention, because like complete cessation of airflow for 10 seconds or more is like too much of an ask. So some books also mention more than 90% reduction in airflow also as for more than 10 seconds also as a defining criteria for the apnea with obviously increased respiratory effort. Okay. Then what is hypopnea? Hypopnea is defined as, see, as the name says, it is not as severe as apnea. So there will be reduction in the airflow, but not complete cessation or not more than 90% reduction, right? So there is two definitions of hypopnea. One is decrease in airflow by more than 50% for 10 seconds with increased respiratory effort. In all these definitions, increased respiratory effort is a key component word that we will be listening. The simple reason is because we need to differentiate it from the central sleep apnea. Increased respiratory effort with, okay, this is important here, with desaturation or drop in SpO2 by more than or equal to 3%. Okay, this is one way, or the another way of defining hypopnea is decrease in airflow by more than 30% for 10 seconds or more with increased respiratory effort, okay, with desaturation of more than or equal to 4%, right? If there is 50% reduction, then 3% desaturation is enough to call that episode as hypopnea. But if it is less than 50% but more than 30% reduction in airflow, then we need 4% or more desaturation. That episode will be called as hypopnea. The time duration for both of these symptoms is 10 seconds, right? If it is less than 10 seconds, then those episodes will not be called as apnea or hypopnea. Okay. Now, what is AHI? AHI is nothing but apnea hypopnea index, which is equal to number of apnea episodes plus number of hypopnea episodes per hour of sleep. So if like patient had 6 hours of sleep, and if let me say he had total 20 episodes of, like, okay, let me simplify it, total 24 episodes of hypopneas and 12 episodes of apnea, right? Then the for 6 hour period, patient had 36 hours of apnea and hypopnea episodes, 36 apnea and hypopnea episodes in 6 hours. So what is the average per hour in that case? 36 by 6, that becomes 6, right? That becomes 6. So can I say that this particular patient I'm talking about has the obstructive sleep apnea? Well, yes, I can make the diagnosis provided this patient has signs and symptoms, right? I can make a diagnosis in the absence of signs and symptoms if patient has 15 plus AHIs per hour of sleep. Okay, now this is the diagnostic criteria. For this, limited sleep study is adequate, but polysomnography can give us more details from the EEG, and for that reason we need to also remember or be aware about something called as RERA. Okay, so what is RERA? RERA is nothing but those episodes of reduced airflow which are also lasting for 10 seconds or more, that are accompanied by increased respiratory effort and arousal, but do not meet the criteria that we discussed. Do not meet the criteria that we discussed for apnea or hypopnea. Criteria for apnea or hypopnea, we call them as RERAs. Okay, there's one more way of diagnosing the OSA, that is based on RDI. RDI stands for respiratory disturbance index. So it is nothing but similar to AHI, but in addition to the number of apnea plus hypopnea episodes per hour of sleep that contributes AHI, we are also adding the RERA events per hour of sleep. We call it as RDI. Okay, so in simple words, RERA is equal to RDI is equal to AHI plus number of RERA events per hour of sleep. Okay, if you are using RDI for the diagnosis, then you have to remember that the numbers remain same here. So RDI of more than or equal to 5 per hour of sleep plus signs and symptoms, we can make the diagnosis of OSA. And in the absence of the symptoms, if the RDI is more than or equal to 15 per hour, then also we can make the diagnosis of OSA. Okay, now the American Association of Sleep Medicine primarily talks about AHI. So for all practical purpose in the exam, write AHI. If you have time, only write about RDI. And for MCQs, focus on AHI. Okay, so I hope the diagnosis is clear. Now we are already aware of the pathophysiology. We are aware of the consequences of OSA, right? There is increased risk of hypertension, type 2 DM and pulmonary hypertension, leading to increased risk of mortality. And also poor quality of life is taking a toll on their academic performance or workplace performance. So for all these reasons, we need to treat the patients of OSA. And when we think about the OSA, right, treatment wise, can we do something to mitigate the risk factors? Well, family history, nothing much can be done, but obesity, yes, it can be addressed. And if there are anatomical abnormalities of the upper airway, that can be surgically handled, right? Okay, so then comes the question. Treating obesity is helpful to what extent for the management of OSA, right? That's a very important point indeed. So tell me now, is that the mainstay of treatment? What studies have shown is that weight loss improves the symptom profile of the patients, right? They reduces the apnea hypopnea index per hour of sleep, but may not be sufficient for most of the patients, right? It is a standard recommendation, but that's not the standalone treatment that we offer. Okay, and also there is an important recommendation in 2023 from the American Association of Sleep Medicine, is that we don't need to go for the definitive management, or we don't need to treat OSA of all patients. So when is the treatment indicated, right? So treatment is indicated, or a definitive treatment is indicated definitive treatment indicated if OSA is coupled with impaired quality of life, or it is coupled with increased daytime sleepiness, or patient has got hypertension. So in presence of these, OSA need to be, like patients with OSA need to be offered definitive treatment. Okay. In the absence of this, probably lifestyle modifications and weight loss are the standard recommendation. Anyway, anyone who is obese, we will definitely suggest them to go for weight loss. Okay. Now the question is, what is the definitive treatment? Right. So if you're asking me what is the definitive treatment, I think we are all familiar. The definitive treatment, or the treatment of choice is continuous positive airway pressure, or CPAP. That is the treatment of choice. So basically what we're trying to do here is we're trying to achieve the airway patency. We're trying to reduce the obstructive episodes by maintaining the positive pressure in the airway throughout the respiratory cycle during inspiration as well as expiration. All the guidelines are very clear that we should prefer CPAP over BiPAP. Clear? Okay. Now, CPAP is one of those therapeutic intervention which is definitely associated with patient satisfaction. Like most of these patients, when we start on CPAP, initial few weeks they might complain because it needs some time for customization, but later on they will be really happy with the treatment because their daytime quality of life improves, their daytime alertness levels improve, and slowly their metabolic parameters also start showing improvement, right? Okay, but it definitely has some side effects or pitfalls. What are the side effects? Okay, one of the side effects is it is associated with nasal stuffiness, and it might lead to development of rhinitis in some of the patients. Okay, and the 2023 guidelines do recommend that we can think of treating these patients with nasal corticosteroids for a short term. Corticosteroids for short-term treatment. Okay, so that is one side effect. Then second, we will be using the interfaces, right? Like to deliver this positive airway pressure, we will be using either face mask or nasal devices or oral devices or helmets. There are various interfaces. Recommendation is preferably use a nasal device. That is the standard recommendation. But like most of these devices are bulkier and they can make the patient feel claustrophobic. So claustrophobia is one more limiting factor with respect to CPAP, claustrophobia. Okay, then anything else it can cause as a side effect? Well, it can cause aerophagia because we are continuously delivering the air to the oropharynx, so it can cause aerophagia, and many patients do complain of difficulty in exhalation because the airway pressure is positive and the patient's respiratory effort needs to overcome that. They might have difficulty in exhalation. So these are the common side effects associated with the CPAP therapy. Okay, now if you ask me, right, what adjunct treatments are recommended, as I've already told you, weight loss is definitely recommended. Okay, is there any other drug recommended like modafinil? Modafinil is used off the chart. It is not a standard recommendation from the guidelines to increase the wakefulness during the daytime, because if you address the night times problem, anyway the daytime problems are solved. So the guidelines focus on addressing your nighttime problem rather than just making you awake with the help of stimulant medications during the daytime. So there is no standard guideline which recommends use of modafinil or any of the stimulants. And also guidelines are very clear that there is no role of SSRIs. So only additional thing is obesity, weight loss. Yes, you might think of surgical management of upper airway, either anatomical abnormalities, or also there are certain specifically designed surgeries which can achieve a better patency even when there is no anatomical abnormality. Those can be considered. Okay, so to give you a summary, management OSA treatment is indicated only if there is impaired quality of life or increased daytime sleepiness or hypertension. Yeah, I forgot to tell you that this impaired daytime sleepiness is assessed using a scale known as Epworth sleepiness score. Sleepiness score or scale. Okay, now this score is a questionnaire based scoring system which tries to assess how likely you're likely to fall asleep in different circumstances, right? And the maximum possible score is 24, and when score is more than 15, right, it is highly suggestive of high risk daytime sleepiness, and 11 to 14 is also significant, so it is like high daytime sleepiness. And when it is 11 to 14, it is suggestive of moderate daytime sleepiness. In both these cases, we should initiate the treatment. So in simple words, I would say Epworth sleepiness score of 11 plus, we should initiate treatment. Okay, hypertension is like standard diagnosis of hypertension according to prevalent guidelines will be taken here for the definition of hypertension. Okay, the treatment of choice is CPAP, right? Weight loss is supportive and surgical management can be considered in selected set of patients. Now, before I wind up the topic of OSA, just a quick look at the recommendations from the American Association of Sleep Medicine. Okay, so this is the 2023 guidelines practice parameters for medical therapy of obstructive sleep apnea. Let us quickly go through the recommendations. First recommendation is on weight reduction, which says successful dietary weight loss may improve the apnea hypopnea index in obese OSA patients, right? So weight loss should be considered in patients who are obese. Now we have to also remember that the studies have shown that this cannot be the therapeutic modality, because most of these patients will not be able to sustain their weight loss, and weight often bounces back to their pre-weight loss journey reading. So it should be coupled with the CPAP. Okay, so that is first recommendation. Then secondary recommendation, next recommendation is dietary weight loss should be combined with a primary treatment of OSA. Primary treatment of OSA, as I've already told you, that is your CPAP. Okay, bariatric surgery may be an adjunctive in the treatment of OSA in obese patients. When bariatric surgery, the obesity parameters meet the requirements or indications for bariatric surgery, you can definitely consider that. Okay, the next recommendation is with respect to pharmacological agent. I think I've already told you none of the pharmacological agents are recommended as of now. So SSRIs are not recommended for treatment of OSA. That is one recommendation. Protriptyline is not recommended as a primary treatment of OSA. That is second recommendation. Okay, then methylxanthine derivatives to be used as a respiratory center stimulants like aminophylline or theophylline are also not recommended for the treatment of OSA. Estrogen therapy is also not recommended for the treatment of OSA. These are all things which were tried in the past, but they are not recommended anymore. The 2023 guidelines does talk a little bit about modafinil, which is recommended for the treatment of residual excessive daytime sleepiness in patients who have sleepiness despite effective PAP treatment. So this is a very crucial MCQ point. I think I've already told you, right? As a initial treatment, we do not recommend modafinil. So this is going to be an extremely important MCQ. So if you have put the patient on CPAP, you have done the titration of the CPAP properly, the settings are all perfect, the compliance is established, and despite that, a patient has excessive daytime sleepiness, Epworth sleepiness score of 11 plus, then only think of using modafinil, not in the beginning of the therapy. In the beginning, try to address the night problems first, right? So this is an important take-home point of the 2023 recommendations. Okay, next is oxygen supplementation. It is not recommended as a primary treatment of OSA because your oxygen does not relieve the obstruction. Okay, then short-acting nasal decongestants are not recommended for treatment of OSA, but topical nasal corticosteroids may improve AHI in patients with OSA and concurrent rhinitis. So I think I've told you this. If patients have concurrent rhinitis, then corticosteroids can be added, but not the nasal decongestants, because see, nasal decongestants, when used for a prolonged period, they have their own set of side effects, and it is not recommended anymore. Okay, then positional therapy. What is positional therapy? Right, making the patient sleep in a position where the AHI is significantly low. Positional therapy consisting of method that keeps the patient in non-supine position in an effective therapy, secondary therapy, or can be supplement to primary therapies for in OSA patients who have low AHI in non-supine versus that in the supine position. Like what we try to do is we achieve positions which are where the patient is not sleeping supine but in a non-supine position. But to recommend this, you should have documented that patient's apnea hypopnea index is low in the non-supine position that you tried in comparison to his supine position. Only then it is recommended. Okay, so this is also an important MCQ point. So there are 3 MCQ points from the 2023 recommendations. One is topical nasal corticosteroids if there is concurrent rhinitis. Number 2, modafinil not as a primary therapy, only to treat residual daytime sleepiness after you have achieved a good titration with CPAP. And positional therapy if apnea hypopnea index is better with non-supine positions. So this is about your obstructive sleep apnea. Now let's move to the next important disorder, that is obesity hypoventilation syndrome. Obesity hypoventilation syndrome, or OHS. OHS. Okay. Now this is a condition where it is typically seen in individuals who are obese, and in these patients there is reduced respiratory effort. So pathophysiology wise, in case of obstructive sleep apnea, though there was reduced airflow because of the obstruction, the response was from the body increased respiratory effort. These patients are obese and there is reduced respiratory effort resulting in hypoventilation. Okay, and this hypoventilation obviously gets accentuated during night. Simple reason is muscle tone decreases, so the respiratory effort as such in physiological state also comes down during night. Add to that pre-existing obesity and low effort, well, everything is getting accentuated. So this leads to again episodes of hypoventilation, hypoxia, and arousals. So the story is now very similar to OSA, though the underlying pathophysiological principles are different. Okay. Now, once the nighttime quality of sleep is gone for a toss, daytime increased sleepiness will come into picture. So symptoms wise, patients will have similar symptoms, right? These patients will have increased daytime sleepiness. Okay. And they can have episodes of hypoventilation, which could have led to hypoxia, and there may be episodes of arousal, microarousals here also, but there is no increased respiratory effort that we generally see in the obstructive sleep apnea. And the trigger here is not obstruction but rather the reduced effort per se, right? Reduced respiratory effort or hypoventilation is the trigger. But as a consequence of all of this, right, hypoventilation and arousals, there is increased daytime sleepiness. The patient will have a same symptom complex. Now, how to distinguish between these two? See, the reason I'm talking about this is, again, this is also very common in obese individuals. So obese individuals are at risk of OSA. Obese individuals are at risk of obesity hypoventilation. So how to differentiate, right? So when I talk about the diagnostic criteria, you will get an idea about how to differentiate. So the diagnostic criteria according to the American Association of Sleep Medicine, the diagnostic criteria 3.0, it says that you can make a diagnosis of the obesity hypoventilation syndrome if patient is obese. So the obesity is defined here as BMI of more than 30, more than or equal to 30. So that satisfies the obesity component, and then we need to document hypoventilation, right? So here we are not pressurizing too much for polysomnography. Instead, how do we document hypoventilation here? We document that by proving that patient has got hypercapnia. Okay. One important difference between the OSA and this obesity hypoventilation syndrome is that when apnea happens in OSA, right, or when hypopnea or those episodes happen, there can be carbon dioxide retention, right? So if I take a ABG in the night time with OSA patients, it will or it might show hypercapnia. But when I take an ABG during daytime, it will not show hypercapnia. But in patients with obesity hypoventilation syndrome, hypoventilation continues in daytime also. The symptom clusters are appearing because those hypoventilation gets accentuated in night, leading to arousals and hypoxia episodes, and thus screwing up his daytime quality of life. But he is having hypoventilation even during daytime. So if I take an awake ABG, right? If I take an awake ABG and it shows awake ABG showing hypercapnia, which is defined here as PCO2 of more than 45 millimeters of mercury, right? Then I can make the diagnosis of obesity hypoventilation syndrome. So this is the most important part of the diagnosis of obesity hypoventilation syndrome. Can I say both OSA and OHS can coexist? Yes, very much possible, right? So especially those patients whom you made a diagnosis of OSA and their daytime quality of life or sleepiness is not improving even after institution of CPAP, I would suggest before jumping into modafinil, right, do a daytime ABG if the patient is obese, and if there is hypercapnia, then he had an added obesity hypoventilation syndrome also, right? So this is the most important differentiating point. Any MCQ that talks about OSA versus OHS, it will mention awake ABG hypercapnia. Okay, now the diagnosis is clear. In terms of management, right, how do we treat these patients? Studies have shown that extreme weight loss of 25 to 30% of their total body weight literally improves their obesity hypoventilation syndrome to the point where they do not meet the diagnostic criteria anymore, because their BMI would have dropped down and their awake ABG will no longer show hypercapnia if they lose 25 to 30% of body weight. But it is not considered as a first line treatment. I'll tell you why. But before that, let me write what is the first line treatment. First line treatment here also is CPAP. First line treatment here also is CPAP, because whatever that nighttime accentuation of hypoventilation that is happening here, right, at least that can be taken care by CPAP, and that improves their daytime sleepiness and quality of life significantly, though a great improvement in hypoventilation doesn't happen, right? Okay, now weight loss is definitely recommended, but the weight loss of 25 to 30% body weight that leads to total improvement is not practical. Is not practical because such weight loss cannot be achieved with dietary or pharmacological therapy easily in individuals who are obese, right? So only bariatric surgery can achieve such weight loss, right? But the point or the problem here is those who have obesity hypoventilation syndrome, right, they will be fitting into the category of extreme risk for surgery, because they as such have hypoventilation, plus the surgery and anesthesia, whole things can get complicated. So most of the bariatric surgeons also do not take up these cases as priority. Rather, what they would recommend is go through some weight loss and then we will later take them up for bariatric surgery. But whatever practically achievable weight loss should definitely be tried. Okay, so this is about the obesity hypoventilation syndrome. Okay, now let me take you to the last bit of the video module, that is narcolepsy. When I teach the sleep disorders to undergraduate students, generally I don't cover narcolepsy because it is like well addressed by the psychiatry faculty. But now that we're talking about the medicine stream postgraduates, I need to cover this topic. Okay, what is narcolepsy? Well, this is also a sleep disorder where patients have increased daytime sleepiness. Okay, often these patients have insomnia at night, but that's not the reason why they have increased daytime sleepiness. So the characteristic feature of these patients is they have increased daytime sleepiness. Okay, and this increased daytime sleepiness often manifests as, right, precipitous sleep. Okay, so what do I mean by precipitous sleep? See, what I mean is normally what happens in obstructive sleep apnea or the OHS patients, when they experience increased daytime sleepiness, right, they will still put their effort to stay awake, and they will be able to maintain awakeness in most social circumstances. Like if I am on the podium and giving a lecture, even if I have an OSA, right, I will try my best to keep myself awake and get this thing done, whatever talk I'm giving, right? But patients with narcolepsy, they will not be able to maintain that awakefulness, right? Once they feel sleepy, they will slip into the sleep regardless of the social situation, right? You may be talking to someone, you can just fall asleep like that, or you may be in the middle of literally driving or giving a lecture and you can fall asleep there. That is one of the key point here, precipitous appearance of sleep, or precipitously they are falling asleep. Okay, that is one thing that we need to know about narcolepsy. Okay, and these narcolepsy patients are often associated with, or it is coupled with, a symptom called as cataplexy. What is cataplexy? Cataplexy is nothing but precipitous decrease in muscle tone. So again, sudden decrease in muscle tone. This decrease in muscle tone can be mild, where they can just drop their neck or something like that, or they can have a buckling of the knees, or it can be severe enough to make them literally drop on the ground. The muscle tone is lost suddenly, right? The sleep appears quite rapidly. Same way, the muscle tone drops suddenly. This event is called as cataplexy. So we don't see cataplexy in the obstructive sleep apnea or OHS, but here it is seen. Okay. Apart from these patients can also have symptoms known as hypnagogic and hypnopompic hallucinations. Hypnagogic and hypnopompic hallucinations. Now, what are these? Hypnagogic and hypnopompic hallucinations. You know what is hallucination? Hypnagogic is those hallucinations that appear just before patient gets into sleep. Like while he is going to sleep, he develops hallucinations, and on awakening, soon after awakening, if he develops hallucinations, those will be called as hypnopompic, right? So while going to sleep, if hallucinations are appearing, and on awakening, if hallucinations are appearing, those will be called as hypnagogic and hypnopompic hallucinations respectively. This is pretty easy to remember. Hypnagogic, go, right? Going into sleep, patient is developing hallucination, that is hypnagogic, and the rest thing is hypnopompic. Okay, so these are the symptoms of narcolepsy. Okay, now how do we make the diagnosis of the narcolepsy? The patients will typically come and tell you that regardless of the social circumstance, I will not be able to control and I just fall asleep. It's like people say that you were talking to me and then suddenly you went into sleep. That is the usual presenting history. Patients also might give you history of drop attacks, because this loss of muscle tone, they may be giving you history of drop attacks. They may be also little vividly describing their hypnagogic and hypnopompic hallucinations. So any patient presenting with increased daytime sleepiness plus cataplexy and these symptoms, we should suspect narcolepsy. Okay, now how do we make a diagnosis? Okay, now before we go to the diagnosis, let me tell you a little bit about what we understand about the pathophysiology. It is believed that the narcolepsy is believed to be an autoimmune disorder, because it is seen at increased frequency in individuals who had certain viral infections. Of late, in recent times, there are studies establishing the link with H1N1 infection and subsequent development of narcolepsy. So it is believed to be an autoimmune disorder. So it is believed that there is autoimmune destruction of the neurons. Which neurons? Mainly what we call as orexigenic neurons. Autoimmune destruction of orexigenic neuron. Autoimmune destruction of orexigenic neurons, leading to all these symptom clusters. Okay, so for diagnosis, what we need? For diagnosis, we need to prove that patient has got signs and symptoms like increased daytime sleepiness and cataplexy. Okay, and we need to prove that there is dysfunction of the orexigenic neurons. Okay, so once we prove that, we have the diagnosis of narcolepsy done. So for that, let me take you through the American Association of Sleep Medicine International Classification of Sleep Disorders version 3, which is the latest one. According to that, narcolepsy will be diagnosed as narcolepsy type 1 if patient has excessive daytime sleepiness daily for 3 months. Okay, see, remember please, psychiatrists also follow DSM-5. Now we are on the verge of DSM-6, those criteria for the diagnosis of narcolepsy. But most physicians and pulmonary medicine specialists rely on the American Association of Sleep Medicine. So I'm going through this. Okay, American Association of Sleep Medicine criteria. The DSM criteria, I think it says that patient should have at least excessive daytime sleepiness for at least 3 days a week for 3 months. Here it is daily, right? In the ASM criteria, it is daily. So patient should have excessive daytime sleepiness daily for 3 months and one or both of the following. What are those two things? A patient who presented with excessive daytime sleepiness for 3 months on a daily basis, either he should have cataplexy, okay, and the cataplexy should be accompanied by mean sleep latency of less than 8 minutes and 2 or more than 2 SOREMs on MSLT. I know you may be thinking, what is this? I'll tell you, but before that, let me also take you through the next point. Low or absent CSF hypocretin levels. So I told you, right, for diagnosis, we need symptoms of increased daytime sleepiness and cataplexy, or we need to prove that there is dysfunction of the orexigenic neurons. That evidence is coming from this low or absent hypocretin 1 levels in the CSF. So if there's a question asking you CSF analysis is required for diagnosis of which sleep disorder, your answer is narcolepsy, right? Okay, now what is this sleep latency and what are these SOREMs? So sleep latency is the time taken from development of light stage of NREM sleep from the awake full state, like fully awake to the light stage of the NREM sleep, the time taken for this to appear. That is what is called as sleep latency. Now, normal sleep latency is more than 15 minutes. So if I'm awake and if I have to make a transition into sleep, it will take at least 15 minutes or more before I am found asleep. If it is less than that, it is abnormal. And for this, the diagnostic purpose of narcolepsy, we are using the sleep latency of 8 minutes or less. But please remember here, it says mean sleep latency. That means we are doing a study called as multiple sleep latency test. So patient is made to go through multiple episodes of sleep, and then for every episode a sleep latency is calculated. So the investigation here is multiple sleep latency test, and a mean sleep latency of 8 minutes or less than that is supportive of diagnosis. Plus patient should have 2 or more than 2 SOREMs. What is SOREMs? SOREM stands for sleep onset REM. Okay, so it is basically the sleep onset REM phase of the sleep. See, normally what happens is when we get into sleep, first we go through a prolonged period of NREM and then the REM phase of the sleep appears. But if in narcolepsy, right, as soon as you enter into sleep, you slip into quickly from NREM, you quickly slip into a REM phase of sleep, right? So if the patient slips into REM phase of sleep within 15 minutes, it is pathological. So SOREM is defined as appearance of REM phase of the sleep within 15 minutes of the sleep onset. Okay, and if more than or equal to 2 such episodes are documented on the MSLT, then that satisfies the one of these criteria, or as I've already told you, low or absent hypocretin 1 levels. Okay, when these criteria are met, we typically call it as narcolepsy type 1. And in the DSM-5, there is only narcolepsy type 1. So you can say that the classification of the ICSD-3, right, it is also including another form of narcolepsy which is not part of the DSM. So this DSM criteria calls narcolepsy type 2 as hypersomnolence disorder. Hypersomnolence disorder, because it does not typically fit into the description of the narcolepsy that we have discussed so far. Okay, so what is narcolepsy type 2? Here also patient is presenting with excessive daytime sleepiness, and his multiple sleep latency findings are similar to what we have described earlier, right? What is that? You have sleep latency of less than or equal to 8 minutes and you have more than or equal to 2 SOREMs, sleep onset REM phase of the sleep, that is development of REM phase of the sleep within 15 minutes of falling asleep. Those things are there, but their CSF hypocretin levels are either not known or they are above the threshold for narcolepsy type 1. So there is a defined levels for the hypocretin values in the CSF. If it is more than that, then we will be calling it as narcolepsy type 2. Clear? Okay, so that is about your diagnosis of narcolepsy. Summarizing it again, narcolepsy type 1 is diagnosed when you have excessive daytime sleepiness, plus one or both of the following. What are those? Number 1, you have either cataplexy, or cataplexy is there, it is enough, or you have sleep latency of less than or equal to 8 minutes and more than or equal to 2 sleep onset REM phases on multiple sleep latency study. Or like the second thing here is your CSF hypocretin 1 levels which are 0 or low, right? That is how we make a diagnosis of narcolepsy type 1. For narcolepsy type 2, it is all similar, right? Patient has excessive daytime sleepiness plus his multiple sleep latency study is very similar, but these patients do not have the hypocretin values and they also generally do not have cataplexy. I forgot to tell you. So this is in terms of symptoms, they have excessive daytime sleepiness, right? Multiple sleep latency study shows sleep latency of less than or equal to 8 minutes and more than or equal to 2 SOREMs, but generally they do not have cataplexy, no cataplexy, and CSF hypocretin 1 values are more than threshold required for diagnosis of narcolepsy type 1. Okay, so this is how we diagnose. Now coming to its management. Okay, so this is one phase or one part of sleep disorders where extensive research is happening and various orexigenic substances are being tried. But we have to remember that they're all in the clinical trial phase. As of now, we can consider using, see, there are 2 sets of symptoms here. Yeah, I think let us approach it that way. 2 sets of symptoms. One set of symptom is cataplexy, which is really problematic. And second set of symptom is increased daytime sleepiness. Right? So for increased daytime sleepiness, we can use stimulant drugs. Okay, but they are no longer like your amphetamine and all are no longer recommended because they come with a side effect. So what is recommended is, one, we can use modafinil. So modafinil for this indication is approved by the US FDA, and there is also one more drug which is recently approved for treatment of the increased daytime sleepiness. That is, the second drug that is approved is solriamfetol, which is a monoamine uptake inhibitor. Both of these are approved for improvement of daytime sleepiness, but they do not help their cataplexy much efficiently. So there is only one FDA approved drug which improves the cataplexy. So the FDA approved drug that improves the cataplexy is called as sodium oxybate. So this had been an MCQ in one of the NEET SS examination before this general medicine based paper came. I think it was for pulmo and critical care section, asking you which of the following is a recently approved drug for cataplexy treatment in narcolepsy patients. The answer is sodium oxybate. It is the only drug which is approved for treating cataplexy. Modafinil and solriamfetol are for improvement in the daytime sleepiness. Okay, so that brings us to the conclusion of this video module. We started with 2 questions. Now with all the information we have, let us go back and see if we can answer those questions. Okay, so the first question was this: which of the following sleep disorder is associated with low CSF hypocretin 1 levels? Now the answer is very clear, right? Hypocretin 1 levels go down in narcolepsy because there is destruction of orexigenic hypocretin type of neurons, which is believed to be autoimmune in origin, right? Various viral infections have been implicated. Stronger evidence links it to H1N1, though it is still not conclusive. Clear? Okay, next question. A 40-year-old male, obese, hypertensive, on treatment, presented with history of snoring at night and increased daytime sleepiness. Now these symptom complexes are suggestive of either OSA or obesity hyperventilation syndrome is also a possibility, and there is also a possibility that it can be narcolepsy because there is increased daytime sleepiness. It doesn't mean that someone who has primary snoring or upper airway obstruction should not develop narcolepsy. It's also a possibility, so let us keep our fingers open. Now here they are mentioning that ABG it was done during daytime, so it is an awake ABG that they are talking about, and the awake ABG shows PO2 of 81, so there is no gross hypoxia, but there is definitely hypercapnia or hypercarbia, pushing the pH2 slightly on the acidotic side. So what is the most likely diagnosis? So in OSA, there is no daytime hypoventilation or apnea hypopnea episodes, so there will be no hypercapnia. Okay, so in primary snoring, say what is primary snoring? Primary snoring is a condition where there are mild airway obstruction episodes happening leading to snoring, but there is no apnea, hypopnea or rara kind of episodes happening. So there is no arousals happening here. So patient snores, maybe he makes the partner get aroused, but not awakening doesn't happen for the patient itself. So primary snoring is kind of a benign disorder. At least for the patient, it is benign disorder. Okay. Now medication related sleep abnormality, well, it's not a possible explanation here, because see, there are drugs, like if patient consumes Red Bull or stimulants during night, then the nighttime awakening can lead to daytime increased sleepiness, but neither question mentions about the history of any such drug abuse, and such drug abuse does not explain the hypercapnia. So the only condition that explains the awake ABG showing hypercapnia is OHS. So that is our diagnosis. So I hope that helps. With this, I'm signing off, guys. I'll see you in the next video module discussing one more interesting topic. Till then, have a good preparation, go through all the Q banks, and all the best, guys. Thank you.